COVID-19 vaccination in immunocompromised patients. We know this is a moving target since the beginning of the COVID-19 pandemic in 2021, end of 2020, when the vaccines were first developed and available. And now in 2024, I'll give you the current where we are, but really trying to take us through the history as to what does this mean for our immunocompromised patients and what have we learned for this. A little bit more about myself. I am a transplant infectious disease physician focused on a lot of clinical work, particularly in our stem cell transplant patients and our solid organ transplant patients. And I'm also a clinical investigator and lead some clinical trials. So COVID-19 and immunocompromised patients. Well, first, let's take a step back. What do we mean by this? Because as we know, there are many conditions and treatments that can qualify a person to be considered immunocompromised, such as those that have undergone a solid organ transplant, a recent stem cell transplant, undergoing treatment actively for hematologic malignancies or a solid tumor malignancy. They might have a primary immunodeficiency or active HIV infection with a very low CD4 count, or they're on other medications such as high-dose corticosteroids for a prolonged period of time, or other immune weakening medications, particularly some biologic agents such as anti-CD20 like rituximab, et cetera. And we know that in general, even before COVID-19, we know this for other viruses, and we have learned this the hard way with COVID-19, that our immunocompromised patients suffer from often more severe illness than our immunocompetent individuals. So why is this? And this comes to the fact of how our different immune responses are to the virus SARS-CoV-2. I won't go into all the details of it, but I have it here so that you can review this. But we know that there's adequate immune responses. It requires timely innate adaptive responses, a quick type 1 interferon response, activation of efficient antiviral response in order to clear the virus by the macrophages, as well as activation of our T helper 1 cells and B cells to produce neutralizing antibodies. When you have an inadequate immune response, as we often see in our immunocompromised patients, we suffer from this, and our patients suffer from this because they often go on to have an accumulation of activated macrophages that can lead to a cytokine storm, as well as some of the other points that I've listed there. So what are these immune-related risk factors for susceptibility to severe COVID-19? Well, we know that older individuals have an impaired B cell and T cell immune response versus individuals who are younger. Having an impaired B cell response leads to a reduced ability to mount a neutralizing antibody response, just like having an impaired T cell response. As we learn more and more about the role of T cell responses in the control of ongoing SARS-CoV-2, we recognize the importance of this in actually fighting the virus once the virus does enter our cells. Younger individuals with impaired or dysregulated B cell or T cell immune responses are also at risk. Therefore, we know that SARS-CoV-2 has significant impact on our immunocompromised individuals who suffer from this impaired immune regulation. How prevalent is this? Why do we need to learn about this? Well, we estimate it comprises at least 7 million of our adult population in the United States. We know this number is only growing as more and more biologic agents are being seen to be efficacious for different disease states. And we've learned in 2020, 2021, and 2022 that these patients who are immunocompromised are more likely to get severely ill from COVID-19. Why and what are they at higher risk for? Even now in 2024, when we know that the virulence of the current circulating variant strains are less so than what we faced in 2020 and 2021. Well, we know that immunocompromised individuals have a prolonged SARS-CoV-2 infection and can shed their virus for a much longer period of time. And there can be some viral evolution that occurs during infection and treatment. They're more likely to transmit SARS-CoV-2 to household contacts, and there is a lower antibody neutralization titers to SARS-CoV-2 variants compared to immunocompetent individuals. And what we saw in the beginning of 2021 is that these individuals were more likely to have, quote unquote, vaccine breakthrough infections. We no longer think about this as vaccine breakthrough, but we learned a ton about this earlier in the pandemic. So what do we think about in terms of vaccination and immunity? This is a very high-level, simplistic view, but I think it's an important overview to think about before we get into the vaccines. So we know that a vaccine activates adaptive cells we think about the B cells or our humoral response as those antibodies that are needed to recognize the virus and block the infection from entering our cells, as compared to once the virus has entered the cells, we need our T cells to really help in order to kill the infected cells so that we don't to fight back. So we don't then have this become overwhelming in one's body and have it continue to really overcome one's system and then lead to this very strong inflammatory response. So what did we used to refer to as vaccine breakthrough infections? Well, this was initially when we were seeing patients that were vaccinated and still then getting COVID-19. Well, now again, an outdated term. Now we think about it in terms of those who have been vaccinated. What has been their humoral and T cell response? How robust has it been? And therefore, how efficacious can we think about it in terms of this vaccine for our patients? We know overall there's a lower vaccine effectiveness among immunocompromised individuals. This ranges anywhere when we think about just the initial primary series from being anywhere from 59 to 72% efficacious among immunocompromised, and again, grouping immunocompromised patients compared to 90 to 94% among immunocompetent after the second dose of our messenger RNA vaccine. Immunocompromised individuals, particularly our solid organ transplant patients that we have so much data on, as well as our now oncologic patients, rheumatologic patients who are on medications that weaken their immune systems, we know that they mount a less robust humoral response, particularly post-COVID vaccine compared to immunocompetent individuals. We know that their T cell function is also impacted, but particularly what we have so much good data on is a less robust humoral response. Well, you might be saying, why are we now in 2024 going back to the primary series? That was so 2021. Well, yes, while that may be true, it's very important because we learned so many great principles from this. And what we also realized is that, not surprisingly, this is what mirrored what we know exists in our other vaccine responses in our immunocompromised patients. And we're fortunate that we have such a great body of data now and science that has come from learning what are the issues in terms of vaccinating our immunocompromised patients. So this was looking at the proportion of subjects with antibody responses after just the 2 initial messenger RNA COVID-19 vaccine doses separated by immunocompromising condition. Small study, just 63 patients. But what I love about this is that it really kind of separates out, again, who do we mean by immunocompromised and who are the ones that we should be so concerned about? In blue, we have our cancer patients. In green, those patients that are undergoing hemodialysis due to end-stage renal disease. In yellow, our organ transplant patients. And we see that at this point, when this was put together, there were so many more studies in our organ transplant patients compared to then other immunosuppressive therapies. So we know overall, the percent of individuals that have these different conditions who mounted an antibody response was lower compared to the blue dotted line of healthy controls. But we also see how much lower our organ transplant patients compared to, let's say, our hemodialysis patients. And so this really hammered home what we already know, which is the fact that we must be thinking about what it means to be moderately or severely immunocompromised, and not just in general, someone who has some risk factor for being immunocompromised, because it very much differs in terms of the robust humoral response an individual is able to mount. So what are some factors that most contributed to having a positive antibody? Well, this was a study that we did here at the Brigham. And what we drew from this in looking at this in terms of our solid organ transplant recipients, and I want to focus on this, is that abdominal organ transplants, rather than a thoracic organ transplant, patients were more likely to mount a positive humoral response or have a positive antibody. Those who are further out from transplant, which makes sense in terms of the fact they are on often lower immunosuppressive regimens. However, that also means they're older and not being on mycophenolate or MMF. These were the factors that were independently found to be most contributing to having a positive antibody response. Again, here looking at the years out from transplant is really nice, and it's something that's been modeled and shown in other vaccine responses as well. So now let's go back to this quote unquote vaccine breakthrough infections, or really lower efficacy to vaccine response, or lower response, I should say, to our vaccines, and therefore overall lower efficacy. We know that prior studies demonstrated this increased immune response after our 3rd COVID vaccine dose when given 1 month post 2nd dose in our solid organ transplant recipients. This was a randomized trial that was really a landmark trial at the time at 2021, published in the New England Journal of Medicine that showed in a cohort of 120 patients that were randomized to either getting a third COVID vaccine a month after their second dose of the messenger RNA vaccine, compared to 57 patients who did not get a vaccine and got a placebo dose, that we know that they had a much more robust response in those who did get the third COVID-19 vaccine. You may say, well, that makes sense. The more vaccine you give, the better the response. But that's not always the case. That's not been always shown in flu vaccine. That's not been always shown even in our regular data now, or regular non-immunocompromised data, I should say, for the RSV vaccine, as far as how much more bang can you get from giving additional vaccine doses, But here we saw this. And this was so important and really led to guideline changes. So yet after this, we still had many questions. We didn't know what was the optimal timing of the additional vaccine dose in immunocompromised individuals. Was it important to get it a month after, or what if you waited 2 months after? We had studies that looked at that. Could you augment the response even more so if you waited 2 to 3 months? And now we've seen that the ideal time to get another booster after getting the third vaccine dose is waiting closer to anywhere from 2 months to 4 months. What about a mix and match strategy with the messenger RNA COVID vaccine response? Does this impact the overall response if you get the different types of the messenger RNA COVID vaccines? What is a correlate for immune protection, and does measuring the SARS-CoV-2 spike antibody actually impact clinical care? This is still the holy grail, and this is still what we don't fully know, but now it's become a lot noisier because of the fact that we know we can have a positive spike antibody, and yet what does that actually mean? Does that actually have efficacy in the current circulating variant strains? So what was the objective of our transplant study when we looked at this in terms of the COVID-19 vaccine? Was, does a third mRNA vaccine dose administered 6 months post-second dose enhance humoral immune response in our transplant patients? So what if we spread this out? Well, we looked at this among our 236 solid organ transplant patient recipients, and we gave them their third vaccine dose instead of a month after, 6 months after. They were either heart, lung, kidney, or dual organ transplant recipients. They had not received a COVID vaccine prior to transplant, because this was, again, back earlier before they could have had access to the COVID vaccine before transplant. They did not have COVID-19 infection prior to receipt of their third vaccine dose. And then back in February 2022, we looked to see, did they get COVID-19 infection, and what was their overall survival? So what I want to just highlight here is a proportion that had a positive antibody post-third vaccine dose. Out of this 236, we had 56% of the cohort, so just more than half, that had a positive antibody response, compared to 44% who did not. Well, what were the antibodies responses? How high did they go? And how did this change? Was this very uniform or whatnot? So what you see here is by the different colors: red for heart, blue for lung, in which we had 72, and 51 for green. These we're looking at before the third dose compared to after the third dose, again, administered 6 months after their second dose. What was that delta? What was the differential as far as the increase in the antibody response? And then if you can see those lines, that those patients that were more than 10 years out from transplant are denoted by the triangle, compared to the circle of those that are less than 10 years out post-transplant. So in our multivariate analysis, we saw that those who are aged older than 60 years old, those that were a number of years out from transplant, like we showed before, that the longer you're out from transplant, the more likely you were to have a better response after that third vaccine dose. And we know that you are less likely to if you had, again, the thoracic organs, lung, heart, or if you were on mycophenolate. So again, similar findings that we saw after the second dose as compared to now after the third vaccine dose given 6 months after. And then we know that the months between the post-third dose of COVID-19 and developing COVID was around 3.7 in those that had a positive antibody, 4.2 that had a negative serology. Overall, the mortality was not different in the two cohorts. So what did we draw from this? We just drew that despite the extended interval of 6 months, the proportion of non-responders, 44% of our cohort, was similar to other studies when the third dose was given 1 month post-second vaccine dose. Significant factors to having a positive spike antibody post-third vaccine dose included age less than 60, having abdominal organ transplant rather than a thoracic transplant, being more than 10 years out from transplant, not being on mycophenolate. And a similar proportion of individuals had COVID-19 infection post-third vaccine dose, irrespective of having had a positive or negative antibody result. Again, going back to, is this a correlate for immune protection? The median time to COVID-19 infection was 4 months post the third vaccine dose. So now let's take a step back and think about what are additional strategies that exist for those immunocompromised individuals who do not mount a robust humoral response to vaccination. Well, this was an excellent study that was published in March of 2023 that looked at different strategies to increase the immunogenicity of COVID-19 vaccines in our kidney transplant recipients. This was from a Dutch study, a randomized control study that compared three strategies with a control single dose messenger RNA 1273 vaccination in our kidney transplant recipients. And so this was done between April of 2021 and July of 2021, of which 12,158, so quite a large number, of kidney transplant recipients, 3,800 who had a functioning kidney transplant participated in this national survey for antibody measurements after COVID-19 vaccination. Of these, 1,311 did not seroconvert after their second vaccination, and another 761 individuals did not even seroconvert after even having had a third vaccine. From the seronegative recipients, 345, or half of those patients, agreed to participate in a repeated vaccination study. So this was vaccinated again with two of the messenger RNA vaccines that was found not to be superior to having a single messenger RNA vaccine, with a seroresponse rates of 68%, compared to 63% and compared to 68% respectively. So again, this is a double vaccine dose, a heterologous vaccination, or temporary discontinuation of mycophenolate, mofetil, or mycophenolic acid. And this is really important because so many studies at this point have shown and demonstrated what we showed here at our own study, that the presence of, or the patient being on mycophenolate was one of the independent risk factors for not mounting a humoral response. And so therefore, this study very nicely looked at, well, what if you temporarily put MMF on hold? Do you then have a better response? But overall, this is not what was seen. So what it showed was repeated vaccination does increase SARS-CoV-2 specific antibodies in our kidney transplant recipients, but we did not see a further enhancement by use of a higher dose or a heterologous vaccine or discontinuing mycophenolate for 2 weeks prior to getting the vaccine. So other studies have looked at different other regimens for holding the mycophenolate dosing for a little bit longer afterwards. But ultimately, what we really feel in the transplant community is that holding mycophenolate can have potential risks to our transplant recipients. And also, it does not seem to have that much benefit. Sure, if we could hold it for a much longer period of time, would it help? But probably not something for us to focus as much on in our transplant recipients, as it is perhaps in some of our other disease states, let's say our rheumatologic patients who are getting rituximab. Well, then the timing of when we vaccinate very much should be taken into account in the overall strategy of our vaccine responses, because of the fact that we know we can play around a little bit with when we are giving rituximab, if it's a regimen for which we need to give it every 6 months, for example, then is it a case that we try to give the vaccine around the 5-month mark prior to having at least a month before giving it again, and also being 5 months out from having gotten the last dose, to really try to augment it. This has not been studied so well to show us independent risk factors that this is independent predictor of having a better humoral response, but these are all thoughts that should be taken into account. But ultimately, what we really have learned from our vaccine studies for SARS-CoV-2 is that we should leave the patient what the patient needs from their underlying disease. We should leave those medications in place. And instead, we should really be studying what are the right optimal time periods to give the vaccine additional doses, and how many additional doses help to augment it. So let's take a step back for looking at one other thing. And in addition to what we know vaccines can do, what about passive immunity of the humoral response, if you will, passive immunity of antibodies? So why are we thinking about this? Well, think about this in terms of the role for neutralizing antibodies. So we know that neutralizing antibodies blocks the ACE2 receptor to try to prevent the SARS-CoV-2 virus from entering the cell, and therefore preventing the cells from becoming infected. Doesn't help to fight the infection once the virus has infected the cells, but helps to prevent that from happening. Why was this important? Well, this was important when we thought about over the past few years of monoclonal antibodies that bind to the spike protein that we could administer for treatment once a patient got COVID-19. Well, I put this up there just for historical purposes. None of these current monoclonal antibodies that I have listed here are now effective in our current circulating variants and for SARS-CoV-2, and therefore we are not currently using any of these. But it's important to remember that we can get the vaccine is trying to get our own immune systems to mount the humoral response by giving monoclonal antibodies its passive immunity and giving that to our patients, and particularly those that we saw from these studies who benefited the most were those who are immunocompromised, who are less likely to have had already a robust immune response. So I put this up there because hopefully we know there are more monoclonal antibodies for treatment that are in development, and it's always an important strategy when we think about different ways to augment the vaccine response, if you will, by going around a different way and doing passive immunity. Well, what's another historical thing that we should just mention here is what about the pre-exposure prophylaxis that we used to have? And this was another monoclonal antibody combination that is no longer available by the FDA because it no longer is effective against the current circulating variant strains. But it's important for us to highlight this because Tixcliv, which was as how this was commonly referred to, showed a 77% reduction in those who developed symptomatic COVID-19 in a PROVENT study, which helped to lead to the approval of the FDA EUA for this pre-exposure monoclonal antibody prophylaxis. And so this was wonderful. And this was something that we really were able to roll out in our immunocompromised patients. But unfortunately, then this became no longer effective against our current circulating variant strains. But fortunately, just recently, this spring, Pemivibart was another monoclonal antibody that was now received FDA EUA approval for COVID-19 pre-exposure prophylaxis that is effective against our current circulating variant strains that we can now give. This one requires a 1 hour infusion with a 2 hour monitoring period. And given the half-life, does require this to be given repeatedly every 3 months. And time will tell for how long this will be effective, depending on the way the SARS-CoV-2 variants evolve. So now I'd like to transition to 2 questions. The first is, I am an adult. You have an adult patient here in 2024 who you are seeing in clinic who underwent a stem cell transplant 6 months ago and have had 1 or more doses of a COVID-19 vaccine in the past prior to undergoing a stem cell transplant. What is the current recommendation? Get a first dose of the updated 2023-2024 COVID messenger RNA vaccine. Get a second dose 3 weeks after the last dose. Get a third dose at least 8 weeks after the last dose. Get 1 dose only of the updated 2023-2024 COVID vaccine. It depends. Or A, B, and C. Well, I want to first address E. It depends. That's always the right answer when it comes to COVID-19 because of how constantly changing this is. But I say that only a bit in jest because we do currently in June of 2024 do have recommendations for this that we know will continue to evolve. But I think the principle is important. And the principle of this is that all first 3 after stem cell transplant, given the fact that we have really wiped out the immune response and are changing that, we revaccinate like we do for our other vaccines. And so therefore you restart it and you get those 3 vaccine series, but now it's all in the updated 2023-2024 COVID messenger RNA vaccines that are recommended. Get the first dose, the second dose 3 to 4 weeks after, I should say, not just 3 weeks, it'll be 3 to 4 weeks, depending on which of the vaccines that are given. And then a third dose, at least 8 weeks after the last dose, which has been shown to have a more augmented response than just getting it 4 weeks after. There's also been an additional recommendation that now you can get another vaccine dose 4 months after having gotten your last vaccine dose. For those that were previously vaccinated, it is not a stem cell transplant, but let's say it's a solid organ transplant recipient who got the updated 2023-2024 COVID mRNA vaccine in September. What do we then do now, 8 months later? They can get it again once they're at least 4 months afterwards. Vaccinated and immunocompromised individuals no longer have an increased risk of hospitalization and death from COVID-19 compared to non-immunocompromised individuals. Well, unfortunately, as of 2022, this was still not seen to be the case, that we know that vaccinated and immunocompromised individuals still had an increased risk of hospitalization and death from COVID-19 compared to non-immunocompromised individuals. Fortunately, the further out we are, we do see this trend going down slightly in the terms of immunocompromised patients not having nearly as high a risk of hospitalization and death, but it's still there. And it's important for us to remember this, to counsel our patients on this, because COVID-19 is still very much circulating, and SARS-CoV-2 very much still impacts directly and indirectly our immunocompromised patients. Thank you all so much. And here is my reference slide. Thanks for joining me as we now discuss COVID